My name is Larry Tannenbaum. I have the honor of moderating this session. I'm not really used to dancing around, but I'll try to face both sides. We have several speakers who are going to join me on the podium today. I see Dennis Wall, who is an associate professor of pediatrics. It's from Stanford University. And I see Peter Chang, a neuroradiologist like me, who is now the director at the Center of AI and Diagnostic Medicine at UC Irvine, just around the corner. And if we're lucky, Dr. Aminian will magically appear on the couch. Right now, he's being filled in by that pillow. And he's going to talk to us as well. But I have the opportunity to open the session and sort of talk about what I see are the real challenges and opportunities and dilemmas in my space. And I am a neuroradiologist by training, but by career, an advanced imaging expert. And I have followed all of the advances in MR and CT, and to a certain extent, PET, since the early 90s, having the unique opportunity of having this technology, new technology in my hand for each year for 20 plus years. For the last 4 years, however, after a stint in private practice and a stint as the director at Mount Sinai of Advanced Imaging, I'm now actually the chief technology officer, hard to say, for the largest freestanding outpatient imaging organization in the United States. Some 330 centers, who knows, 10 million exams per year. 700 plus radiologists, 7,000 employees. So the issues where AI interfaces with imaging space, and that's where I'm going to lead this discussion, are really near and dear to me and essential for our survival. So let's talk about what we have going on out there. We know a few things, right? I think we know that the amount of research going on in deep learning is going up quite a bit. And as you can see from this little pie chart, the majority of it is in diagnostic imaging. Whoa, I'm getting something up here that is not mine. There's a couple of cute women and a koala. I was wondering if you can...
No, it's not mine either.
I'm not going to say where I find more attractive. What you can see from this slide, and now I can see from this slide, is that the majority of this work is going on in diagnostic imaging. We're not neglecting cardiology, and we're not neglecting pathology and laboratory, but diagnostic imaging is the sweet spot for a lot of this technology. You can see from what's going on out there, it is clearly the imaging space. You'll see if you look at the lower right-hand corner, left-hand corner. I knew there was a reason I asked for a mouse. Every once in a while we'll want to point, and if you look over here, you can't look over there, you can't see it. You can see that preliminary diagnosis and automated diagnosis is right there on the top 10 list, and that's really what we're here to talk about. When you look at the applications that people think they're going to use deep learning for, you notice some interesting things. You see some things that are near and dear to me. We have a lot of issues in our organization getting our breast images read. So, I think we're probably not alone seeing 70% as on that list, but you'll notice there's also lung, because lung screening is a great application. You see there's some work going on in liver. I worked a little bit with an organization, little organization called Watson on a liver AI application for LIRADs. But you'll notice you don't see hemorrhage. You don't on that list when it comes to brain. You see neuroaneurysm, which is interesting since a lot of the products we're seeing now are in hemorrhage, and they're just starting to make some inroads on aneurysm. But a broad range of applications for these things to play in. And you can see that the actual adoption, with some products being FDA approved and some products approaching that are 510K pending, you're starting to see some adoption building. And you can see if you look at this chart, and it's really not a well-designed chart, but you can see from looking at this chart that roughly half of the respondents are either beginning to use this or thinking about beginning to use this, and really only about 16% are thinking that this is not something that's going to affect their day-to-day practice. By the way, that's how you cheat 7 slides into one, just in case you didn't notice. Well, I just got punished by having my microphone fall out. The good news is I don't need the slide change for about a half an hour. So, the real question now becomes, how do we use these technologies to elevate the imaging process or to elevate the imaging enterprise? And there's a lot of opportunities here that we're either seeing early applications or a lot of interest. And these are all things that make a difference to me in my role in this big organization. One of the things that we can use these tools for is for utilization management. What studies are appropriate where? As you know, we're being tasked to come up with clinical decision support. It's a very difficult process fraught with all kinds of challenges. This is something that really could help us. And we have some value-based, risk-based arrangements in our organization. And how do we manage the imaging in that population so that we don't end up in the red? These are tools that can help us. Insurance processing. Some 10% of insurance filings are rejected. Some 70% of insurance filings are questioned up front. That can cause a lot of administrative load and delayed payments. These are things that make a difference. And upfront collections. This is something you may not think about, but we looked at the difference between what we do collect up front and what we actually collect up front. And if we figured that this tool would help us in a significant way to identify this up front, this is worth some $25 million a year to our organization. So, that's a real opportunity. What about other things? What about the process? We have sites that have 30% no-show rates. What can this technology do for us to predict those no-show rates or help avoid those no-show rates? We tend to use fairly crude scheduling processes. Everybody gets a half an hour. Some exams are longer, some exams are shorter. Invariably, patients get inconvenience. Couldn't we design a more dynamic scheduling process to maximize the use of these expensive machines? I tend to live in the imaging space. That's where I cut my teeth. And we're already seeing FDA-approved tools to reduce the amount of contrast we use for PET scanning. There are tools that are approaching commercialization that will allow us to use 10% of the gadolinium contrast and still get the value. We're also seeing now, if you went to this year's RSNA organization, you saw several vendors already selling a deep learning tool for reducing the dose associated with CT images. Now, we've had other tools, but they've met with mixed reviews. And with these deep learning tools, they essentially restore the gold standard quality, but deliver today's at even lower doses. But again, patient-centric imaging, patients don't like to stay on the scanners. If we can get off faster, we're going to have happier patients, and we're already seeing those applications coming to pass. And frankly, it's not just about speed. There are tools in deep learning that deliver super resolution, make an image at X resolution, upscale it to a higher one, visibly sharper, better value. These are tools we're seeing out there. And frankly, you hear lots of discussion about leveraging the clinical info that we don't have in our hands very effectively. Radiologists laugh when you ask them, do they have the patient history? We don't, we barely get a patient history of any relevance. We need tools that will scrape the EHR, deliver the genomic information, pull the key piece of information out of our prior reports so that we know to address them on the subsequent exam, and even design the protocoling of the exam so that it's done optimally for the patient's clinical needs. There's the word augmenting, very popular in this space. We can augment our interpretation process, what we deliver from interpretation through these triage tools, which have real relevance. And we have commercially available triage tools that will say, in that stack of 150 cases, there's a couple of cases that may very well have a stroke, may very well have a hemorrhage. We're talking about, when you see detection, you think about CAD, and we want CAD that works now because we don't want it that slows us down, that has us too distracted by false positives, and we're looking at this technology to help us. And ultimately, we're looking at using, finding a way to supplement and perhaps replace the radiologist diagnosis with these tools in circumstances that are sort of low-hanging fruit and overwhelming volume. As you know, in the UK, and they can be 3 weeks behind on reading chest x-rays. I experienced that as a medical student, and I'm shocked to hear that's going on today. These tools will help that as well. But radiologists are struggling, right? We are working in a circumstance where there is an ever-increasing amount of work. Okay, there is an ever-decreasing reimbursement per unit work, and we need tools that will help us work more efficiently. Get the appropriate priors set up for us. Make our hanging protocols work. I used to click 20 times when I was at Mount Sinai before I engaged my brain. Okay, that is not the efficient use of our high-powered, high-cost talent. Make these tools work for us. And segmentation. I can tell you that I trained for a long time. I've got 30 years of experience. None of that has really made it fun for me to measure lesions in 3 dimensions and try to do it the same way from visit to visit and give reliable longitudinal information. These are all important things. And frankly, when it comes even to the reporting process, we're talking about reports that are targeted to the audience, perhaps. Maybe a different report for a general practitioner than for the neurosurgeon who's consulting on that case. Maybe a report that can, through NLP, communicate to a patient without freaking them out with the detail that might scare. Reports that auto-populate with data that's been extracted from the images could be very helpful. Maybe helping us make sure that we have our key data elements in our reports so that we make sure that all the clinical questions, positive and negative, are answered. And of course, smart reports where perhaps the best images go in automatically would also be nice. So what challenges remain? Okay, as these technologies approach clinical utilization, how do you pick the companies to work with? How do you pick your partners? Do you go in there with a partner that perhaps is going to approach the broad needs in a broad way? Your partner will build the algorithms as you need them and transfer learning them over to the next application and the next application. So find a partner that will attack this market in a broad way. Say my friends in Atlantic are a good example of that. Or do you go with someone that has an individual app? Hemorrhage detection, fracture detection. That may not be the economic model that works in those circumstances. Or say breast imaging, where I have a ridiculous amount of images to read. I have a constant issue in recruiting radiologists. I have an increasing amount of volume per individual case, and there a partner might really work out by giving me the deepest dive on the most maybe economically compelling individual application. The economics are really a challenge. How are we going to pay for these applications? Okay, what's the model? $5 per chest X-ray? You might get laughed out of our organization under those circumstances. Okay, $1 per wrist fracture? That may not work either. The model for how we're going to pay for these has not been established, and it's really not clear. And the other piece is, from an administrative point of view, is who's going to pay? I've got, what do they say, 1,000 radiologists, and we're in a room, and they're reading a bunch of mammograms, right? Okay, so now there's a tool that has an X per exam price. Who pays that price? Is it me, who wants greater productivity, wants these studies read, owns the technical side? Or is it the radiologist who now can read more exams, who has an easier time reading those exams? These are real questions that have not been answered that I think we all should be considering. We're kind of getting around to where the implementation would be. I think most of us think it's going to somehow find us at the PACS. But there are some applications that really don't belong on the PACS. They don't belong in the cloud. They don't belong from a third-party vendor. They belong on your hard metal device. If I have a tool that's going to accelerate my MR scanning, that's going to reduce the dose of my CT scanning, I don't want to buy it from any small company. Okay, I want it provided for me on the device, and I think the best pathway for those companies is to negotiate agreements with the hard metal vendors, and I think that's the only way that's going to fly. I think we have challenges in the enterprise for interoperability. Things don't talk to each other. We've got to move in that direction. And frankly, we got to start looking at our infrastructures now. What is it going to take to move all this data around to partners to different circumstances? We need to make sure we build these, the highways for all of this data. Now, regulatory is a really interesting issue. When it comes to replacing radiologists, let's say, radiologist looks at a film, he's been trained to see everything that's there, every possible variation on normal, or in this space you might call that anomalies. Your approvals, however, are never look at everything on a chest X-ray. You don't get it to approve. The FDA is not going to say you can read a chest X-ray. They can say, well, you've proven you can see a pneumothorax. You've proven you can see a lung nodule. You can probably even notice aortic ectasia. But you haven't proven to me that you can see everything that might come up in those circumstances. And there's the challenge, because a radiologist sees things holistically. Approvals are individual and specific, and that's a challenge. And then acceptance. Administrators, they have their concerns. Is there going to be the appropriate cybersecurity? Do we have the bandwidth to these circumstances? Is this the best vendor? The physicians, the nurses, the other folks in the healthcare enterprise, they have their own concerns, and of course, patients. You ask patients today, will you accept a computer making your diagnosis, augmenting your diagnosis? You hear a decent amount of negative feedback, but I frankly think that is just a sign of the times, and that will probably shift over the course of time in the appropriate circumstances. And then, legal. I think with legal, it just comes down to, in our environment, in this world, if something goes wrong, who do you sue? Okay? Do you sue the company? Do you sue the startup in the corner that made that application? It's a difficult thing. We know in cardiology for a while, we've sort of figured out years ago that a rules-based algorithm can read an EKG pretty well. Okay, does a pretty good job. So the insurance company said, you cardiologists have been looking at these, we've been paying you, but we don't need you anymore. The computer algorithm does just fine. Seems like a good plan. So the cardiologists, they were busy guys. They said, fine, we won't look at these anymore. And then it became, well, who do we sue if something goes wrong? Let's go pay the cardiologist again. So it's an interesting piece, where the legal liability will fall in these circumstances. So with those concepts laid out for you, only one or two, I'd like to hand the podium over and the stage over to Dennis Wall, who will go ahead and give his presentation on what is on his mind in this area. You shouldn't need that too many times.
I don't have anything in radiology on my mind. I apologize. So, first of all, thank you. This is such an honor. I love this conference. It's a real privilege to be here for me. And I did make one slide, but it's very animated, so it has a lot of features to it. So I wanted to begin this dialogue and hopefully kick some discussion off with some experiences from my own space. I think this has come up already a lot in this conference, and the notion that for AI and medicine to be successful, we have to be innovative, creative, risk-adverse, in order to be able to develop alternative strategies that completely circumnavigate the current standards of care. And this is happening. Of course, in this room, there's absolutely no shortage of brilliance and creativity to create these new things. You can see today that we have a number of papers in a special topic produced by PLOS Medicine on machine learning, artificial intelligence, and healthcare that have covered basically everything you can think of, from lung cancer to cardiology, cardiac health, to inflammatory diseases, to orthopedics, to developmental wellness and health in children, pediatric health. And of course, that's a little bit of where I'm coming from. I founded the company Cognoa, and that company began in my lab at Stanford 6 years ago, almost 7 years ago. The ideas, these early creations that we made, thinking about how do we circumnavigate the current standards of care, which we believed at the time, and we still believe today, are broken, and calling out for alternative solutions that can stem from artificial intelligence in health. And to that end, we've created technologies that can enable rapid diagnosis through AI on video, enable delivery of therapy in a continuous fashion at home through augmented reality wearables, which is meant to be indicated here by the Google Glass picture. And that's great. And one of the things we just published, I think, sort of puts a stamp down on the opportunities and potentials in this area. But the question is, how do we move it? How do we move it forward into clinical practice? How do we affect the translation? Because translation in this case isn't just innovation in publishing and PLOS Medicine, it's actually adoption, use, payments, alignments of incentives. One of the things that my friend and colleague Atul Butte recently tweeted is this notion, it looks like California in this case is winning. It has its own unique color in its delivery of mobile solutions for medical data medical data transfer between stakeholder, patient, and clinical site. This is great, but it's also not scalable. It has issues with adoption. It has issues with usability, in particular, issues with usability at the interface of invention, AI, adaptive models, and the use of these data for improved healthcare. So encouraging, but I think we can do better. And I would like to open it up for discussion on that as we go into the discussion section. But the way that I think about this is doing better requires a platform and paradigm to be thinking about the innovation that needs to happen in this space. And that paradigm embodies essentially three axes. A platform axis where we're going increasingly from an active platform, an MRI machine, for example, to a passive platform like a phone, along an axis that starts with subjective measures, which include morphology, behavior, gross morphological analysis, potentially by trained clinicians, to a more objective space. And finally, going from rare to ubiquitous technologies. I should have said that differently, but anyways, you get the idea. These three axes enable you to at least to think about how to create novel solutions that move along this axis. And this is starting to happen. Cognoa is one example of that. Pear Therapeutics is potentially one example of that. Achille, other companies like this that are coming up in the digital health space are beginning to move along these axes in the right direction. Obviously, all of these things require FDA regulatory approval, and that is where I think we have to open up the dialogue. We already heard several times today about beginning discussions as early as possible with the FDA, and this is something that we're experiencing at Cognoa, getting in line, beginning to communicate with the FDA about what we're doing and why we're doing it and working with them. They've just published, actually last Saturday, nearly a week ago, a new update to their medical device, software as a medical device policies. And there it begins to show you, do I have a laser pointer? This thing does not appear to be laser pointer friendly. Some of what can happen in this space. That's not going to work anyways. Okay, anyways. So over there you've got a little flow chart. That flow chart describes, it's directly from this December 8 publication from the FDA. It describes their line of thinking for producing software as a medical device. I'm taking more time because I know this is not a third person.
I thought I had that time.
Anyways, and so what the middle box, which I hope you can see, includes this reference data knowledge base. This is an interesting concept because ideally that we can create something that's static, or at least static for a period of time, that we can use to benchmark against when building an adaptive model. And this is something that Cogno is thinking about. Building something that can be adaptive, dynamic, embody the principles that we believe are important in artificial intelligence and delivery of healthcare, get smarter as you go, do better, personalize as you go, and do so by benchmarking against a gold standard. Of course, you have to have the FDA regulatory approval in order to be able to move things forward for payment structures and to get adoption. It's exactly what Cogno is facing now, a resistance essentially to the adoption. You've heard it took me 6 years to get where we are now, maybe 7 years to get where we are now, and we're not there yet, but we're getting close. So I would say a few things to think about. Moving from like the FHIR-based medical apps that are being pushed out from UC centers, like those that Dr. Butte are running, to a more personalized control where the stakeholders are increasingly becoming empowered by ubiquitous devices to deliver information to clinical care and bridge the gap between what they need and what we can give them. We also have to have a policy and a mechanism in place to be able to take artificial intelligence models, vet them in a consistent fashion over time without having to wait before final approval. We can get an initial approval, iterate, and continually refine and tune as we go. And I think the FDA is starting to get there. Adaptability and retest performance is what I mean by that. And of course, getting to an early dialogue with the FDA is of the utmost importance, because without them, it's very difficult to move these things to translate them to clinical practice. And so breakthrough designation helps. That's not always possible. It's what we have with Cogno. This creates fluidity of conversation so we can move the process forward faster. But I think more of this has to happen, and it is, and I'll leave it at that and open it up for discussion at the end.
Thank you.
Oh, yeah.
So I have no slides because we were told at the beginning to try to create one summative figure, and I see now the very loose interpretations of one slide. So I've got it now. But for those of you that didn't get a chance to catch the session yesterday, let me introduce myself a bit. My name is Peter. I am a neuroradiologist, so a clinician by training, but in fact spend the vast majority of time working as a software engineer and data scientist, trying to actually develop these tools as part of a new AI initiative at the University of California, Irvine. Now, on the occasions where those two jobs don't keep me busy enough, I spend what limited free time I have left trying to run a company as a CEO, looking at trying to translate some of these tools into actual commercial products. Now, I provide this background because in order to appreciate and understand the challenges and opportunities for deep learning and AI and imaging, which is what we're about here right now in this session, you really need to consider the problem from all the various different facets and really try to find the intersection of applications that are most viable, right? So Larry gave a great introduction where we saw virtually unlimited numbers of applications, and that's what we're seeing throughout this meeting is the potential, right? There's so many things that it can do. In reality, in some ways, AI can almost theoretically do everything, right? But the truth is that today, there's going to be very specific opportunities, a very specific slice of applications that we're most likely to translate. And that's what I want to cover a little bit with my time here. So as a clinician, the first thing I'll recommend is that before you even set off on that journey to make that first product, right? Make sure that what you're building is clinically relevant and useful. I'll give you one example. A very popular thing people love to do in radiology is to try to diagnose cancer on the image, right? Look at the image of some sort of mass or abnormality and tell you whether or not this thing is a bad cancer that needs to come out. Now that sounds really cool and sexy, right? Diagnosing cancer without any surgical intervention. And in fact, a lot of tools now are approaching a degree of accuracy that is certainly impressive. But the truth is, as a clinician, that tool is almost useless to me, right? Because what is my job as a radiologist on the images? It's not to say this is cancer or not, right? Oftentimes my job is to just tell you whether or not this finding is suspicious enough that it needs to be worked up further. It needs a biopsy or it needs to go to surgery, right? My imaging is imperfect. I'm never gonna get to 100% accuracy, right? And again, that's not the role and purpose of imaging. So by contrast, when you develop one of these tools and you get to that accuracy and you're like, wow, I can look at this mammogram and give you a 99% accurate prediction of whether or not there's cancer here. Don't gotta do anything else, right? Well, at 1 out of 100 misses is a lawsuit every single time. Right? 99% is not good enough in this particular situation when the alternative to care, pathology, is much more accurate than that. So that's actually not a useful tool to me. Now, in addition to the role of applications in the clinical setting, right? When you actually design the algorithms, right? Now, putting on my technical hat, there's quite a bit that still needs to happen and that we need to think about when we come up with useful tools, right? So the reality here is that while AI can do almost everything, there's very specific types of applications from a technical perspective that we have architectures and we have well-curated tools to do already, right? Things like objectively evaluating an image, right? Not telling you a diagnosis, but simply going through and telling you which pixels on the image are abnormal, right? That sounds very trivial, but just that alone will get you a large amount of very useful applications with quantification, segmenting different anatomic structures. The other part about this that I would also kind of point out and deviate to is that as I'm going through these different points, one of the key things to consider is the important interplay between all the different people here involved in this process. I'm talking about some clinical things, I'm talking some technical things. Trying to merge those two together is another key part of finding that special place where actual applications come to life. For the technical piece, what I'm referring to is actually integrating the degree of clinical domain expertise into your algorithm building. Right? Too many times what we see is that you take a generic off-the-shelf algorithm from Google or Facebook, does very well in one particular domain, and people are taking that exact same architecture without any modification and throwing it at a radiology or imaging application. And while you get some good initial results, right, the reality is that the things we do in medicine are highly customized. If you don't build that degree of customization into your architectures, you're going to see a plateau in your accuracy and again, a limit in the types of applications that you're going to be able to build. The last part of this puzzle that I'll talk, I think I have just a few moments left here, is the commercialization or translational aspect of this work, right? Because no matter how good your clinical question is, and no matter how good you build the application and build the technical nuts and bolts, if you don't have a clear regulatory pathway to getting your product out to commercialization, you're never gonna succeed, all right? By contrast, if the FDA goes and opens up a new 510 clearance pathway, right? Every startup will notice that and start to move their roadmap to line up with what's possible. In imaging, what we see now is a specific new pathway. In addition to CAD-E and CAD-X, which we've had for decades, there is now a CT triage, computer-assisted triage category that is about a year old. And again, as soon as this pathway came out, we see now every AI startup in this space, in radiology imaging, moving towards triage applications. So what is CT triage? Well, rather than marking the image as a traditional CAD-E or CAD-X might do, the goal of CAD triage is to go through an imaging exam and simply flag it as being abnormal or normal. Right? So nothing else about anything inside the images, just a global assessment of whether or not there's an abnormality in image to triage it. The problems, well, it turns out that even though these products are now starting to flood the market, it goes back to kind of the clinical perspective, right? So if I flag an entire image as being abnormal and I click on it and I see that, okay, there's an abnormality, then no problem, right? I clear it and I move on with my work list. But in the case of a false positive, when the algorithm picks up an abnormality that it thinks is urgent but is in fact normal, I, as a radiologist, will now spend 2 or 3 more time on that image than I would otherwise, because I don't want to miss that other finding that the AI picked up that I would miss. That, in fact, now slows me down considerably, right? And because of the way these algorithms are made and because of the performance statistics, false positives significantly outweigh the vast majority of findings that you see. So there's still some problems here. Again, it's a nice start, and we do see some applications in this space now using this particular clearance pathway, but by not being able to actually annotate those images, you lose a lot. So I think, we kind of went a little bit over here. I'll close on that note, and I think we're going to open the floor up for some discussion.
Well, that was a great start. Some pretty disparate information from the strict radiology pitch all the way through, and I think the best way to leverage who's on the panel is to sort of let the discussion go where we'd like it to go. And I would suggest that we may actually have time to take questions from the room. So if you want to formulate some questions, we may very well be able to pull on you and grab those from you. But let's see if I can come up with a question, because so many things were occurring to me while we were going through. And I think this one, is a good one for us all to consider. You were talking about the approval process, and you were talking about essentially the validation process, which are all tied in together. And to me, the FDA approval process, which has been clearly designed to try and facilitate what we're doing, is not really suited to proving the validation, right? When we test on our own sets with a limited number of cases, it almost makes you giggle when you hear that you're going to get your approval off of performance on 300 cases. But more importantly, after you leave the womb and go out to a different population, a different circumstance, maybe just a different machine, maybe just a different protocol, things are going to change. So I look at this as an approval to use, okay? But they still have to evolve, right? So both of you folks are representing concerns. There's lots of concerns in the room. How do you approach your customer with full disclosure that what they're buying necessarily is a right to try, and it is not a finished product, so to speak? How do you manage their expectations that it may not work right out of the box, and you may need to continue to work on developing that tool? It may be very powerful. It may change everything that we do, but it's probably not ready when you get it. How do you explain to your potential customers and to your potential investors as to what's going on out there? How do you make that clear? And what are your perspectives on that? Take as much time as you need.
I think there's my quick answer to that is there's probably little difference with that than there is, seeing that versus the variability in opinions across doctors who are performing kind of frontline care. So you take primary care settings, general pediatrics as an example. The variability of decision making in that space is big. It's bigger, definitely, than what we can render on a machine, in fact. So I think customers, stakeholders, patients, et cetera, are comfortable with the notion that the opinion you're getting, even diagnostic, is it comes with a variability. It comes with a certain level of indecision potentially. There's a variability. I'm not sure what the right word is, but we can say, okay, the published accuracy of this classifier, which renders an autism diagnosis versus not an autism diagnosis, is 97%. Or we could put it differently, that the area under the precision recall curve is 0.93 or something like that, depending on what they want to hear. But 3% matters, and that 3% is still realistic. It's still out there in the population. We still need to be aware of that. So we have to be able to say there's high accuracy, but this is a decision being made in a way that's trained to be appropriate, but can sometimes be ineffective.
And the expected evolution of the functionality of the product?
So I've got a lot of ideas on that, but I wanted to give you, if you want to have a chance on this one.
Yeah, go ahead and answer. You can follow up.
I'll build on that by highlighting the fact that the challenge is more so not so much technical, right? So there's ways technically to try to build teams and retrain and keep developing the algorithms. But from a regulatory perspective, there's no clearance pathway for that. When you get approval from the FDA, it's for a frozen product that you've built and validated on a specific data set. And there's no mechanism right now, currently at least, to retrain that algorithm to make it better or customize it for each specific institution.
Well, it gets back to what I showed in my slide. If you have a database against which you can benchmark and you build a new model, you can submit the performance of that new model as an amendment to the claims on the previous model, as either being as good as or better than. And that is sufficient for FDA to move forward with an approval of that as an amended solution to the previous solution. And so I think that's a workable system in the current setup of the FDA. I think over time they need to be more dynamic in terms of how they adapt to the adapted models and make decisions on them. But right now, I think that's an effective working solution.
All right, so...
But sorry, do you mind if
Go right ahead, go right ahead.
I liked your comment about the the clinician having a holistic view of the radiology image in the computer system, or the AI having a targeted approach to it. I think that's how you wanted to put those things. And what I'd like to raise is this notion of capturing the decisions that are being made by the radiologist. So you get a report. It's circled some images, some elements of the image that says this is bad, and you should take a look at this. And in some cases it's right, in some cases it's wrong. To what extent are you recording that information, and to what extent is that being utilized in the system over time? How adaptive is it to your inputs? And in turn, is this field, and this is something that I think is important for the entire field in general, supporting the opportunity to take advantage of those feature label events? This is effectively what you're doing, is creating a bolus of labeled images over time that are supported by your effective decisions, but it's doing so in a minimally invasive way in effect. It's enabling you to take a very quick look at something, deem it right or wrong, and move on. And those right-wrong decisions can get put in, those right-wrong decisions update this example database that could be used to iterate, right? Is that happening in radiology?
I think the reality for people that are making these algorithms and trying them out clinically, the answer is no. It comes to a more sort of operational or from an execution perspective why that gap is often there. So a company that typically makes these type of tools, right, and goes to a hospital and says, okay, here's the best thing we've got so far. Please give us some feedback and let us know how it does. The degree of that feedback typically is, well, it did well in these cases, but it didn't do so well in these cases, and that's it. And if you go with it, well, how about sharing some of that data with us? Do you mind giving us access to some of that data from behind your data center firewall and letting us retrain an algorithm? Unfortunately, most institutions are very hesitant to do that. And then as soon as they, some places will and try to create a contract and move things forward, but as soon as they move to that space, the institution now feels that they've contributed in a very highly significant way to the performance of this model down the road, and now they want a much stronger, tighter type of collaboration. So it's tricky. I think that's the problem right now. It's from a practical perspective, there's a few places where it breaks down.
So we have two choices at this point. I could drag you back to the clinical sphere and talk to you about what I think is really the more compelling applications for the folks in the audience and that they should be developing, which I think is kind of a cool thing. Or I can sort of stay in your space, in the data science space, and they say they're half the room is data scientists, half the room the clinicians, but I'm pretty sure under the shirt, if you tore open the shirt of the clinicians, you would find, data science underneath it and the t-shirt. So, maybe I ask you the challenge as to what do you think needs to be done? What is the breakthrough development that needs to happen? To me, I'm looking at all of the applications. I see the good approaches, the narrow approaches, the broad approaches. I see the winners here, the ones that have data from multiple disparate sources to train on. Not just one country, multiple countries, not just one continent, multiple continents, a variety of sick and well. RadNet is an organization that images outpatients. The algorithms that work for us are really the ones that are trained on healthy people. That may seem silly, but generally when you come to an outpatient, you may have an issue, but you're generally well. Whereas if you train on a Stanford inpatient population, you're generally not well. You're generally ill and maybe with a really exotic set of diseases. So from your perspective, holistically and, with the wisdom that your background and interest brings, what do you see as the landmark achievement that needs to go on that gets us to the next level beyond these limitations, beyond the challenges we are today?
I'll let you start.
All right. I was sort of getting at this in the last little dialogue. I think one of the biggest failures and opportunities so far in our advances in AI and medicine has been the ability to capture information while we work and use that information in important ways. What's rate limiting in computer vision AI? The biggest thing that's rate limiting is the number of quality examples that we have to train the models. I forget who said this at the conference last year, but a person gave a wonderful talk and described the artificial intelligence that differentiates dogs from wolves. And it's this incredibly powerful outcome, perfect accuracy or near perfect accuracy, but when you look back at the data, you realize that the reason why it's doing so well is because all the wolves are in snow and all the dogs are not. And so all the model does is differentiates snow from not snow, or hot dog from not hot dog if you've watched Silicon Valley. So it's about the training data. It's about the labels we can generate on, or examples we can feed to our deep learning models. So I think we have to become innovative about how we affect what I call an action to data feedback loop. It's exactly what Cognoa is doing. We deliver solutions at the point of care, diagnosis, while capturing data that's feature rich, on which we can build better models over time. And those models don't have to be specific to the purpose of diagnosis. They can be specific to other things like endpoint measurements that improve our ability to judge the efficacy of a therapeutic intervention program over time. Those are fundamentally lacking in the field of development pediatrics, possibly many other places. We deliver wearable therapy to these kids so they walk around their house and they can see, they get face contact encouragement, make more face contact, and understand what those faces are telling them. But while that's happening, we're generating data that becomes incredibly valuable over time. And so when we're operating in the clinical settings, we're often doing things on paper, we're doing things one-off, we're doing things in a way that doesn't populate a shareable resource of let's say, of good examples, whether they're image examples or other, that we can use to act as the sandbox or armamentarium that enables deep learning. And deep learning is an interesting term and has some interesting math behind it, but without good examples, it's not very useful.
I'm going to build on that in two ways. So the first thing, I think in terms of a landmark breakthrough is what you're describing there, the infrastructure and ecosystem to deliver these tools better than what we have today, right? What we have is this very static model where a company or institution will release some sort of software and then it gets just distributed in mass and that's it, right? There's no synergy or two-way communication between the people who are using these tools. There's no iterative process to make those tools better, is to take that type of feedback in real time and provide something that's better, right? So both from a software perspective and maybe a team of people, like experts that are going to be on the ground and actually making this happen. I think we don't have that at all today. I think a good example is the imaging machines we use as radiologists, the MRIs and the CTs, right? everybody buys the same MRI and the CT from a handful of companies, right? But universally, every hospital customizes it and changes their protocols and builds something that's, makes sense for whatever local context that they're dealing with. So I think that part we're missing. From a clinical perspective, in terms of applications, right? Because again, it comes down to the fact that there's just almost an unlimited number of applications and what to do next and which application will sort of make things stick. In my opinion, all the tools we have currently are at a place where they simply augment something that I do, make me a little bit more accurate, or maybe make me a little bit better in some way. And so what that means from a financial perspective is that it's going to be challenging to prove that this tool is providing me this much more percentage gain and this much percentage difference in my bottom line, which means that it's going to be very difficult for hospital administration to pull the trigger and buy a lot of these tools en masse, right? So what's going to be the one evolution that changes that? Well, I'm a radiologist, so I don't like to say this, right? But I think we're going to need to move to a point where these tools can act autonomously on their own in a small, very focused context. So as an example, as a radiologist, a person that looks at a lot of head CTs all day, I know that over 90% of everything I see is normal, right? We get head CTs for just about every indication, and the vast majority of everything has no pathology on it. So what if I could design a tool that was extraordinarily sensitive? So lots and lots of false positives, right? But when it says that there's no abnormality on image, which may only happen 10% of the time, there's 0% chance that anything could go wrong, right? In that specific context, if you could trim the bottom line by 10% or 20% and say these are cases that a physician never has to look at, that's, I think, where you start to get the buy-in across every hospital, every institution in the country. There'd be no reason not to buy such a tool, right? You price it at 50% of whatever your savings are, and it's a no-brainer.
I'd like to follow that up. Is my mic still on? I was going to say that perhaps the most compelling application, particularly for an organization like ours, is the ability to identify normals. Because we have huge volumes of cases, and the ability to say this group is normal is very powerful. Getting into the theme, they say with AI, easy things are hard, hard things are easy. It's the same type of thing with the radiologist's ability to look at an image. If you tell me there is a high likelihood that this image is normal, I have, as a human radiologist, look at a film and get the same type of holistic feel almost the minute you look at the image. Okay, it's a very quick, instinctive feel from the image that it is normal. So if I had a dilemma, and we do in this country and in other countries perhaps even worse, a mismatch between my capability to read efficiently and effectively and the volume of cases that are out there, if you can triage images as normal and streamline my process, even if I have to look at every single one, and that's where we are today and who knows how far indefinitely into the future, it is a very, very valuable tool, whether it's mammography, which is a very detailed data set, or routine chest x-rays, it works. I mean, it's a very funny, I'm not sure, how many radiologists are there in the room? Anybody? And of the guys with your hands in the air, practicing radiologists ever, or just, in this space? But I can tell you that when I was a resident, we had alternators. An alternator was this big machine, and you would hang the films like this, celluloid films, and you'd have them 4 here and 4 here, and then you'd press a button and it would load 4 more, and you'd end up with 50, 60, 70 on this thing, and you would press the alternator and read the scans, and press the alternator and read the scans. And I trained at USC in Los Angeles, not too far from here, and the chief of chest diagnosis, one day he steps on the pedal, and he doesn't take his foot off. And he goes, normal, 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 stop. Okay, with a presumptive knowledge of normalcy, you can be incredibly effective at picking out the abnormals and being efficient in those circumstances. So I think that's really a real functionality. And for a company like ours, particularly at this stage of development, when you expect the algorithms to continue to improve, this one will probably take off, faster than anything else. So not many radiologists in the room. I saw maybe 3 or 4, right? But you're all building into a space that theoretically is going to find a real presence in radiology, right? So a year ago, maybe 15 months ago, there was widespread panic, white-knuckle fear in radiology spaces. that this technology was going to put us all out of business. Jeffrey Hinton said we're like the coyote chasing the roadrunner. We just don't realize that we're off the cliff, and we look down and it's already gone. The history's already gone. He says his statement, it's quite obvious we should stop training radiologists. And Jeffrey Hinton and I are not close friends, but my understanding is he's done a deeper dive in terms of where we are today in artificial intelligence. And, the short message is not so fast. We're not quite there. Maybe he's not quite off the cliff. On the other hand, how do medical students see this situation today, right? Are we all running for the hills to do something else because Siri's going to take over and do all of my work? Or do they see this as a land of opportunity, as a field that may be richer and more fulfilling and deliver better quality and do better healthcare? And it's an interesting piece. So, in radiology, you may not know, we have, we train them for 4 years. They're medical students they go through, and at some point they say, what do you want to do with the rest of your life? Okay, what are your intentions? And all of the residency programs, neurosurgery, orthopedic surgery, cardiology, radiology, all sort of open up their little stands and say, express your interest in us, and we'll decide whether we have interest in you. It's a match process, right? And in any given program, it's the ultimate mark of shame if you can't fill your spots. You can't find enough interested parties to fill your spots, and that's a mark of shame. And you want to be a program that really fills up. That means that we're good. People are clamoring to our door, right? So radiology match over the last 10 years or so, 15 years, has hovered in the 85 to 90+% of spots filled, right? Of all the programs in all the world, right? This is a U.S. number, so in all the U.S., all the programs, we would fill like 90% of our spots. Now, what do you think would happen if there was a disruptive technology like artificial intelligence that was sending us scurrying away to any other field? You expect those numbers to get worse, right? And there was really widespread concern. But as we started to publicize the potential here, publicize the ability of these tools to substantially elevate the process that I'm involved in terms of making it easier, with less drudgery, with more engagement of my brain as opposed to my back. Okay, it has created the impression that this is not a field to run from, but rather a field to run to. Now, radiology, as long as I went into radiology, because it was the center of the healthcare enterprise. Okay, nothing could happen without the imaging examination. Okay, nothing could happen if you delayed the imaging examination. You had longer length of stay. You had poor clinical outcomes. Radiology was the center. So is radiology going to move out of the center now and be replaced by machines, or is it or is the other possibility that radiology will be even better positioned at the center of all this information, the center of all this technology, and be probably ideally poised to be, a specialty that is highly desirable. So what's happened? Well, it turns out that we were hovering in the 85% range, but the last match, which is right in the middle of this environment, with all the things that are going on and are about to happen, matched 100%. So while there are some concerns, I think medical students are aware of these issues. I think the Canadian Society of Radiology, I'm getting that name wrong, they've been very, very active in the AI space, by the way, up in Canada in terms of organized radiology. They expressed that certain residents were clearly going away from radiology because they were concerned it wasn't the spot for them. I think the overwhelming consensus in 2018-19 is that this is a specialty that is going to be stronger, better, and much more valuable as we go forward into the enterprise. Right now, we're in a situation where, you've got an orthopedic surgeon, a radiation oncologist, maybe an internal medicine guy, and a radiologist sitting at a table trying to divide up the value-based medicine financial pie. Okay, I think what we think in 2019 is that with the tools that we will have that will elevate our capabilities, that we are going to be better situated than ever to get our appropriate share of the pie. And that's the feeling on the ground in radiology, and that might be of interest to all of you folks that are building into this space. The other thing I would say is working with AI concerns. I don't even play an AI guy on TV. I struggle to keep up with the concepts, okay? What I would say though is, and a lot of radiologists are saying, hey, should we become data scientists now? Do I need to know the difference between an generational adversarial network and a convolutional neural network? Do I need to know, the bits and pieces of the GPUs and processing? That's really not what we should be telling radiologists today. The value that radiologists bring to your concerns, to the development and full fruition of your products, is in the domain knowledge, okay? You can clearly go down a path that may not be aligned with where we're going if you don't have the advice of folks in the domain. So that would be my advice to folks in this arena. Gentlemen, we have a couple minutes left. Comments, closing comments?
On that, just real quickly, it's compelling and maybe not surprising, however, that you can examine on the machine that you indicated with the foot pedal thing. I don't know what that is, but anyways,
Too young. You're too young.
Negative. This is Malcolm Gladwell's blink, right? This is the empirical intuition that's developed over time through experience. And it's true in radiology, it's true in pediatrics, it's true in a lot of spaces in medicine. There are people who have an empirical gift to see things quickly and be very confident and accurate in seeing those things. What I would say is if we captured those moments while you're working, we could create AI that would obviate the need for you to look at those images ever, and that you could be sent only the images that are challenging. And that's the power of AI. I don't think it changes the number of individuals needed. It just changes the quality of work you do.
Correct. I think that's absolutely right. The types of technology, the type of algorithms that we have right now are not the ones that can holistically interpret an entire image and generate the type of things that I as a radiologist need to do. The technology that is most imminent at our fingertips are the things that will expedite my workflow, right? Count the number of nodules or measure lesions, right? These are things that, one, take me a long time, and two, are things that I don't want to do. That's not the interesting part of my job. So if an AI can come through and help me expedite all that, be my resident to look at all the images first and give me a preliminary read, that would actually make my job a little easier, and I think in some ways makes it more desirable, as Larry's trying to get at there. Yeah. The last piece I'll throw out there in terms of opportunities and people actually going into radiology, right? This idea of is medicine even attractive anymore? Well, I'll say that historically, medicine has been a field where technology adoption is very slow, right? And it's very tedious, and there wasn't a lot of opportunity. So we actually lost a lot of, I think, really great technical minds to just engineering or startups. But for the first time, with the kind of wave of AI that's coming through, I've actually seen people that are ex-employees at Amazon or Google coming to medical school. They're actually coming and realizing that this is a very real opportunity to be had. And I think that's absolutely the case. While someday in the future we may all be replaced, I think in the immediate future, what we're looking at is a lot of opportunity.
Now, I think I appreciate your comments and your thoughtful integration into the discussion we have today. It was great to be on the panel with both of you. We're just about hit our limits of time, and I'd like to thank the organizers for giving us the opportunity to do this and sort of raise some interesting issues and exercise some thoughts that that we have in our minds, and enjoy the rest of the meeting. Thank you very much for your attention.